Good afternoon. I'd like to thank the program committee for this invitation to talk on the use of shockwave therapy in treating lower extremity tendinopathies. These are my disclosures, which should not have an impact on this presentation. Our objectives today are to look at the proposed mechanisms of action of shockwave therapy, know the risks and benefits of shockwave, and finally list the most common tendinopathies that are responsive to shockwave therapy in the lower extremities. This is an overview I'm going to cover in the next 15 minutes or so. In terms of brief introduction, everybody's seen this variation of tissue injury and recovery. Initially, you have bleeding, clotting, inflammation. There's release of growth factors that attract various cells. Then over the course of weeks and months, you get proliferation of tissue, remodeling. In the course of tendons, oftentimes it's 1 to 2 years or more that you get remodeling of these tissues. Hence, the tendinopathies take a long time to recover. Now, in terms of different treatment strategies, the one thing I want to emphasize is the importance of rehabilitation exercise, which has been discussed in this symposium. I think it is the critical key element in treating tendinopathies. That includes not just the rehab itself, but modifying activities, correcting biomechanical errors, et cetera. There are a lot of modalities that can be helpful for symptoms in terms of heat, ice, PT modalities, manual therapies. There's a variety of medications and supplements that may be beneficial. Just a brief shout out to nitroglycerin patches, which I commonly use in conjunction with tendinopathies, which have good evidence for improving various tendinopathies. Different injection therapies. Obviously, we've gone away from cortisone, which tends to be catabolic, rather to some of these other anabolic procedures, such as prolotherapy, PRP, cell-based injections, et cetera. Don't forget about the power of prayer and cognitive behavioral therapy in terms of the mind-body connect. And then obviously what we're talking about today is shockwave therapy. So what is shockwave therapy? We're talking about some kind of device or energy that's delivered to the tissue that results in a very rapid increase in pressure that's short-lived. And then that's followed by a negative pressure, almost like a vacuum effect on the soft tissues. The end result is this direct mechanical pressure. Mechanical forces may cause tissue damage, stimulating healing, or there may be indirect pressure by this cavitation effect that leads to cell expansion, potential rupture. The end result is the stimulation of growth factors that trigger healing. This microhematoma and increase in cell apoptosis assists with this process. Now, there's lots of different technologies that have been developed over the course of time, including electrohydraulic, piezoelectric, and electromagnetic, as well as ballistic. End result of all of these is this generation of pressure to cause tissue damage to stimulate healing. Now, you can divide shockwave therapy into so-called focused shockwave and radial pressure shockwaves, and there's difference in technology. The focused shockwave therapy, the area of force is much smaller, hence it's deeper, and there's more pressure developed per square inch of tissue. The end result is the thought is that focused shockwave therapy causes more of a cellular type of response. Radial, as the name implies, the force is distributed over a greater distance than the tissues. It doesn't tend to be as deep, and the end result is it's probably more beneficial for soft tissue stimulation. Now, in terms of theories of action, how this works, the first thing is there's no question there's a change in nerve cell permeability. The end result is an anesthetic effect with shockwave. It inhibits pain receptors through depletion of substance P, calcitonin, gene-related protein, glutamate, and others. So the end result is shockwave results in an anesthetic effect. There's also improvement in angiogenesis and blood flow to the area, which brings more inflammatory compounds, inflammatory cells, that increases collagen synthesis, fibrosis, and tissue healing. And then finally, the third major theory is that this damage, the shockwave damages the neurovascular structures, which we feel is what causes the pain of tendinopathies, and hence this causes decrease in pain generating tissues and hopefully recovery. Now, when we look at comparing the research, SEMS published this 15 years ago and it's been replicated since. One of the problems with shockwave therapy is there's so many research variables like there is in any study, and patient selection has a huge impact. A person who's had plantar fasciitis for 3 months is different than somebody who's plantar fasciitis for 3 years, yet they're lumped together in the studies. The equipment used plays a big role in terms of how much energy is delivered, how frequently, the number of impulses, the number of sessions, the intervals between sessions, the method of shockwave therapy, how it's actually delivered. The user has a big impact on this. The use of anesthetics probably has a deleterious effects in the studies in that you numb up the area, you don't necessarily know where to focus your treatment because they don't hurt as much. And also the toxicity of the anesthetics may have a role. We all know that with any study, the placebo and Hawthorne effects are very powerful, and it makes it difficult to do studies. And hence, SEMS concluded, as with many studies, that we need more prospective, double-blind, randomized, placebo-controlled studies. Albeit with shockwave therapy, placebo is very difficult to achieve because patients know when they're getting shockwave therapy, unless they're fully anesthetized. Now, in terms of how much energy to deliver, Professor Knobloch in Germany does not feel that you need to hurt the patient so much. So on that scale of 1 to 10, his treatment focuses on patients having a pain level of 4, no more than 5 in treating the patients. I, on the other hand, have been doing this for a while, feel like you need more energy. And so I tend to increase the energy level so that patients experience a pain level of 8 to 9 for short times, 10 to 15 seconds while we focus on the area. Gradually, that pain level decreases down to about a 5 or a 6, and then I reposition the device, and in all, delivering about 2,000 to 3,000 impulses. So there's a big difference in philosophy. He feels you don't need to hurt the patients much. I, on the other hand, feel like it should hurt. If we look at the number of studies published in the last 30 years, most of them are in focus, but in the last 15 years, have been more on radial shockwave therapy. And in general, if you look at the studies, you can see the diversity of equipment used depending on where the researcher's based, whether it's electromagnetic, which makes up maybe 50 to 60% of the studies, electrohydraulic, or piezoelectric, which makes up about a quarter of the studies. Now, in SEM's original review in 2006, looking at the tendinopathies that seem to have the best literature to support compared to placebo, in the lower extremities, plantar fascia, Achilles tendonitis or tendinosis, and quad and patellar tendinosis seem to have the best benefit. Upper extremity, calcific rotator cuff tendinopathies without full thickness tear, the epicondylitis seem to have the best evidence. And then there's also studies looking at stress fracture, more for high energy shockwave, and medial tibial stress syndrome, if we consider that a tendinopathy. Now, what happens is you get a shockwave device as a practitioner, you start to use it and expand your indications. And so there's lots of other tendinopathies and disorders that have been treated with shockwave therapy. Glute medius tendinopathy seemed to respond well, proximal hamstring, other insertional tendinopathies, retrocalcaneal bursitis, partial thickness rotator cuff tears, although not initially indicated for youth, the apophysinuses respond well to shockwave therapy in many cases. For more focused devices that deliver deep energy, things like femoral head osteonecrosis, osteochondrosis dissecans, fracture healing, difficult stress fractures, and non-unions can be beneficial. For lower energy devices or radial shockwave, soft tissue injuries can be effectively treated with shockwave. And then in some of the chronic conditions of adhesive capsulitis, arthrofibrosis, and osteoarthritis, we have studies that suggest that these may be helpful adjunct. Chen Day in 2018 published a nice systematic review of the lower extremity tendinopathies, looking at the randomized controlled trials. And you can see there's a variety of studies here. And just a few things to point out. About half these studies are radial and half are focused. They used a whole variety of different devices, hence it's hard to compare one study to the other. The frequency of energy delivered, the number of impulses was pretty consistent, over 2,000 to 3,000, although some were less, some were more. Most sessions were anywhere between 3 and 5, and usually they would do it once a week because that's the easy way to do studies. I might suggest to you, however, that sometimes, especially with the elderly, you're better off not treating necessarily every week, but maybe every other week. And with the youth or the younger individuals, they oftentimes tend to respond more frequently, so you can treat them more effectively, so you can treat them more frequently. But their conclusion of this systematic review was that shockwave therapy exerts an overall positive effect on pain and function for a variety of lower limb tendinopathies. Also concluded that the types and dosage levels may have different contributions to treatment efficacy. Hence, the practitioner and the device they use has an impact. Now, what about concerns with shockwave therapy in terms of precautions? If you can't localize the pain very well, patients may not do as well. If you don't have any recent imaging, it's probably worthwhile to repeat imaging because you don't want to be treating a malignancy. Pregnancy is really a contraindication. I generally don't treat pregnant patients. I worry about the energy level delivered and the effects on the developing child. Individuals under 18 years of age initially was a contraindication, but now we know that you can do it safely at younger ages. If they have a pacemaker or AICD wires, you have to be concerned in terms of causing damage to those structures. Another thing I've found over the course of time is to make sure that they're metabolically healthy. Vitamin D deficiency, which is quite common, iron deficiency, which is quite common, hypothyroidism, not so common. These are all things that I make sure are corrected before doing shockwave therapy because I don't feel the patients heal as well. If they have inflammatory bleeding disorders or use of anticoagulants, that's a relative contraindication. However, what we're trying to do is cause bleeding to the area to stimulate healing. And so it's really a minor risk for shockwave. They may bleed more and have more clotting. If there's an open wound, that's a contraindication. However, shockwave can be used to treat diabetic ulcers that are not healing. Most important thing is if you have an uncooperative patient, they just don't tend to do so well. Now, what about some of the adverse effects? Well, when I do it, it hurts. It's pretty intense. People can become vagal, oftentimes diaphoretic. They'll tense up their back and get back pain and muscle pain and radiating pain. That's normal. Skin reddening and bruising is not unusual. This is a patient who I treated the previous week with her glute medius tendinopathy. This is her second session. You can kind of see that erythema around her glute musculature and then all that hemorrhage that occurred along the IT band, which I think is really important to treat when you're treating glute medius tendon to hit along the IT band. But this didn't hurt her. She felt fine and went on to good recovery. Let's see, radiating pain, as I mentioned, is not unusual during treatment. You'll feel the impulses radiating through the joint or up and down the lower extremity. And paresthesias tend to be temporarily resolved relatively quickly. So in my experience with shockwave therapy, it's really important to choose your patients wisely and get them prepared for the treatment. Make sure they don't have some metabolic or nutritional deficiencies. In my hands, in my experience, the patients that are obese, perimenopausal with bilateral symptoms that are relatively inactive with low pain tolerance don't tend to do as well. Now, I don't know if that's because the obesity, you just don't get the energy level down to the tissue, or if it's because of the inflammatory concerns associated with obesity. Perimenopausal women, I think it probably has to do with hormone fluctuations and alterations, which delays tissue healing. I'm not sure of that. In my hands, I think that there's a better response to more energy and more impulses. Hence, I deliver oftentimes 3,000 as opposed to 2,000 impulses. Focused seems to be better for tendinopathy. Using anesthetics seems to impact negatively the outcomes for the reason I mentioned earlier. And also, as I mentioned earlier, in the elderly, I think it's better to treat them every other week rather than every week. So somebody in their 70s and 80s, oftentimes they do better with more interval between sessions. I think there's really a low risk of severe adverse effects. And I will oftentimes retreat at 3 months. I used to retreat at 6 weeks if they weren't better, but I found there's something magic about that 3-month mark that if they improve, if you wait till 3 months, oftentimes they improve. So what are some take-home points? First of all, shockwave is safe and effective for treating a variety of tendinopathies as part of a holistic approach. You can't just do that and nothing else. You have to make sure everything is being taken care of. There's no question there's a difference in technology used, the energy, the impulses, the number, the frequency, the number of sessions, the treatment intervals, and the blinding makes it really difficult to compare studies. And certainly we need more research, good research, to determine the optimum treatment of these various tendinopathies. And with that, I'd like to thank you for your attention. I look forward to the question and answer session.